Hi guys, welcome back. The next topic we're studying is Gullain-Barre syndrome, and this topic was in the news, especially in middle of 2023, especially because of an outbreak of large number of cases of GBS that occurred in Peru in Latin America, to the level that the WHO made a reference of that on its website as well. Though the exact cause for why there was a sudden surge in number of cases was not reported, initially they thought it's probably post-COVID or maybe related to COVID vaccine, but the exact cause for development of this outbreak was not elucidated. And what we are aware of at the moment is definitely that this is a autoimmune process. It's a autoimmune polyradiculopathy. That means the nerves that are coming out of the spinal cord, which are having covering of myelin, is the one that is affected. There's a patchy segmental demyelination, and even the peripheral nerves can get involved in this condition, but the major damage is with respect to nerve roots which are coming out of the spinal cord. So let's look at the villain antibodies in this case, and there are two of them, the names of which are to be remembered. Though the list is exhaustive, I would like you to first remember the name of the villain antibody for Guillain-Barré syndrome, that's called as anti-GM1 antibody. And this is the main antibody causing the commonest variant of GBS, that's called as AIDP, that is acute inflammatory demyelinating polyneuropathy. The data for same, more details of AIDP would be filled up in subsequent slides. There's a second antibody that's encountered in a variant of this condition that's called as Miller-Fisher syndrome. And in Miller-Fisher syndrome, the antibody which is the villain and is to be remembered is called as anti-GQ1B antibody. Now let's look at what these antibodies would be doing. They'll activate the complement system, and therefore there's going to be complement mediated damage against myelin. There would be vesicular degeneration, like if you can see in this schematic representation on the top, the myelin covering is shown to be perfect, but then there is a vesicular degeneration that is occurring because of a complement mediated activation. And therefore two things can happen in these patients. In majority of cases, it's the point number one that would be happening, that is demyelination. In some cases it can be an axonal degeneration as well, and in some of them it would be combination of the two as well. Now because of this demyelination, because the motor nerves are affected, so majority of cases will present with ascending symmetrical flaccid paralysis. The amount of paralysis that happens in the left leg will be exactly equal to the one on the right hand side. So it would be a symmetrical paralysis. First the legs would get involved, person would not be able to stand, then truncal paralysis will occur, so he can't even sit in a chair like I'm sitting at the moment. And then there would be arm involvement as well, that would contribute to quadriplegia. Diaphragmatic involvement can occur, so in about 30% of cases ventilatory support would be required. Neck muscles would get involved, so neck floppiness will occur. Then facial paralysis can occur, bulbar palsy can occur, that they can't even eat, drink, swallow. I mean, things like eating, drinking, we don't even think about. And this person, if you give something to a person with bulbar palsy, high risk of aspiration is anyway there. So demyelination causes development of flaccid paralysis, which is a ascending symmetrical paralysis. In some MCQs, he will also incorporate electrodiagnostic findings as well. And the electrodiagnostic finding of this would be a conduction block. In fact, for the demyelination variety, though of the bad things that I was saying, that person will become bedridden, he will have quadriplegia, can't even get out of the bed, then will have bulbar palsy as well. We do find recovery can occur with demyelinating variety. In about 85% of cases of GBS, there is a functional recovery by approximately 1 year. Obviously, this will require a lot of willpower on the part of the patient, physiotherapy team, doctors who initially were quick in diagnosing this condition, giving intravenous immunoglobulins, which is the drug of choice. In some cases, we even do plasma exchanges. So combination of your diagnostic skills, aggressive treatment, the physiotherapist's contribution, patient's willpower itself, functional recovery occurs in about 85% of cases, as remyelination can occur. However, in some subset of patients, they can also be axonal degeneration. Well, those subset of patients where there's an axonal degeneration, prognosis will relatively be bad. So in the later part of the discussion, you will hear me saying terms like AMAN or AMSAN. AMAN would be acute motor axonal neuropathy. AMSAN would be acute motor and sensory axonal neuropathy. So if there is going to be axonal degeneration, then the simplest way I can explain is that the axons are literally getting disconnected from the neuromuscular junction. You see, if axons are not communicating with neuromuscular junction, then the muscle weakness is going to be pretty serious, and even the recovery process would be severely hampered. So on a comparison basis, what I've tried to give you is a heads up with respect to that two would be having a much more worse prognosis as compared to point number one. And the technical term for point number one, though not written it, I've said verbally, would be presentation of AIDP. That's the term that will be used, acute inflammatory demyelinating polyneuropathy. And sometimes I'll be using terms like AMAN, that is acute motor axonal neuropathy. And as I said, whenever we have an axonal neuropathy, axonal degeneration, then the recovery process will be relatively slower as compared to the part which I mentioned in point number one, where there can be a possibility of a quicker remyelination as well. Let us now look at the causes which could be responsible for triggering Guillain-Barré syndrome. In large number of patients, there could be a GI illness. Like this guy was driving on the highway and he consumed food from a local restaurant and he developed food poisoning. One of the important bacteria which contributes to development of food poisoning is Campylobacter jejuni. Therefore, initially when these patients would come to you, the complaints of these patients would not be that of paralysis of the legs or neurological manifestations. It would be GI illnesses in the form of nausea, vomiting, diarrhea, or in some cases, they can even be presentation of dysentery as well. So, a large number of cases of GBS, the trigger which would be responsible would be Campylobacter jejuni. And for the diagnosis of this condition, majority of time in India, you see the leading cause of dysentery is Shigella. So I will think it is shigellosis, and I might even start fluoroquinolones in these patients. But technically speaking, Campylobacter jejuni is a lot of time resistant to fluoroquinolones as well. So because nowadays integrated questions are coming, so I would just like to remind you that one of the culture media that helps in isolation of Campylobacter jejuni from other bacteria, because there's so many bacteria, different types of bacteria present in the fecal matter. So we need to specifically isolate this one. So one of the selective media that is available is Skiros media. And if they ask you what is the drug of choice for management of Campylobacter jejuni, then we will not answer fluoroquinolones. Though I said in clinical practice, when case will come to you most of the time, if person comes with dysentery, that is blood in the stool, you might be thinking that he is suffering from shigellosis, and you might be giving even fluoroquinolones. But most of the time, due to extensive usage of fluoroquinolones in animals, no, like in poultry, they are using fluoroquinolones in large amounts. Because of that, the resistance has occurred in Campylobacter jejuni. So you would be aware from your pharmacological domain as well that macrolides, erythromycin, sometimes if is not available, or like patient is not comfortable taking erythromycin, it has to be taken multiple times per day. So we might be using a drug that's relatively longer acting. So on a comparison basis, I just wanted to sensitize you to Campylobacter jejuni, which is an important cause of development of food poisoning, and can even contribute to development of blood in the stool, which is why I said dysentery. And therefore, do not be surprised if questions of GBS begin by first describing the episode of food poisoning. The neurological manifestations will occur after a couple of weeks. It might be between 1 to 3 weeks later. So the main trigger is GI illnesses, though that may not be the only situation. And in some cases, there might be respiratory illness as well with the atypical organism. An atypical organism that could be contributing to atypical pneumonia is Mycoplasma pneumoniae. We call this as walking pneumonia. Like in China, in December 2023, you saw a large number of surge of cases of pneumonia, which were reported due to Mycoplasma pneumoniae. And this guy would have maybe recovered from this pneumonia as well, but later neurological manifestations will occur because antibodies which are going to be formed against these organisms will start attacking self, that is, start attacking myelin. So it is, the antigens which are triggering GBS are going to be like bacteria or even viruses that I'll be describing before you. But then the antibodies which are formed against these tend to cross react and cause manifestations after a variable incubation period of 1 to 3 weeks. From the viruses perspective, I would like you to remember regarding cytomegalovirus, then herpes and Epstein-Barr virus. Lots of time in immunologically mediated disorders, these viruses names would always be coming, like cytomegalovirus or Epstein-Barr virus or even HIV. But the special entries that I would like you to remember from the exam perspective would be one, Zika virus. Cases of Zika virus have been reported in initially Brazil and then subsequently in India, also in Gujarat. And post Zika virus cases, not only do you read about children, if a woman has a Zika virus infection in pregnancy, her baby can develop a microcephaly. So you're aware of this. I'll just write down in brackets in this particular case that Zika virus is known to cause development of microcephaly in the baby born to a lady who suffered from a Zika virus infection. But the patient I'm talking about, I mean, this lady, if she had a Zika virus infection, she can not only have this, but the bad news is she can end up with GBS manifestations as well. Another virus that I can mention at this moment worth remembering is hepatitis E. I mean, this is one of the leading causes of acute viral hepatitis. So I can say that hepatitis E, though, is a leading cause of acute viral hepatitis. It's transmitted by fecal route. I'm describing a non-hepatic manifestation of hepatitis E, which would be, or extra hepatic manifestation of hepatitis E, which can be development of GBS. I mean, the peculiar thing is like with hepatitis B, we read extrahepatic manifestations like serum sickness. For hepatitis C in the video, you will hear me talking about extrahepatic manifestation like essential cryoglobulinemia, membranoproliferative glomerulonephritis. So entire list to be remembered for extrahepatic manifestations of hepatitis B. For Bombay, like serum sickness. For C, like I mentioned, MPGN, where we read about that tram track appearance. In the same spirit, in the same, I mean, in the same spirit, you need to remember hepatitis E, extrahepatic manifestation seen in these cases can be even GBS. So that's flaccid ascending symmetrical paralysis, which can in 30% of cases require a ventilator dependency as well. Then couple of vaccines have also been incriminated in causing outbreaks of GBS, that is the influenza vaccines, though the baseline rates are very, very less. The rates were much more higher for the rabies vaccine, not the current generation, not Rabipur or Virorab, the ones that you use nowadays. The older generation of rabies vaccines, the ones that were derived from mouse brain. So whenever you read about evolution of rabies vaccine, initially you read about neural derived vaccines. Those were derived from mouse brain. So older generation of neural vaccines. The latest generation of rabies vaccines would not contribute to it, but the older generation of neural mouse brain derived vaccines were notorious to cause development of GBS like manifestation. And what I'll say next will be very controversial, so I'm putting a query in this particular case, that there was a couple of speculation, and in some studies it has been documented GBS developing after recovery from COVID-19, that is SARS-CoV-2. And what I'm gonna say next should not trigger any panic reaction. It's just mentioned in Harrison that Covishield is what I'm talking about, because we had Covaxin, we had Covishield. So Covishield per se, that is the adenovirus vector derived vaccine. This adenovirus vector derived vaccine that for SARS-CoV-2 has also been shown to be associated with increased risk of development of GBS. You don't need to be alarmed if you received Covishield vaccine. If it had to occur, it would have occurred. But yep, I mean, they did find a couple of associations there, but this is again only few case reports and has not been validated in any meta-analysis. From point number 5, I would just like to say that if a person is having lymphoreticular malignancy in the form of a lymphoma, or is having an autoimmune disorder like SLE, then the risk of GBS is also found to be elevated in these patients. That's again because this is an autoimmune disorder, and GBS also has an autoimmune pathophysiology present behind it. So the risk of GBS incidence or the chances of new cases of GBS would be increased with respect to patients who are suffering from lymphoreticular malignancies or associated with systemic lupus erythematosus. Out of the 5 that I mentioned, I specifically would like you to remember point number 1, because that is the usual starting point of most of these MCQs. If he will himself start by saying distal areflexia, ascending symmetrical flaccid paralysis, it will be a piece of cake for you. So he'll try to waste your time in the first line of the MCQ by describing GI illness, and after 1 to 3 weeks of it, the neurological manifestations will be occurring. I can say that GBS as a disease per se is an immune response to non-self antigens. Like all of these that I've written here before you are non-self antigens. So it's an immune response occurring to non-self antigens. And I mean, the immunity is misdirected. I mean, it should be destroying the bacteria, and look at what it is doing. It is causing polyradiculopathy. It's attacking the covering of the nerve roots. It's going deep enough to cause even damage to the axons, which is why I said that the immune system is basically misdirecting to the host nerve tissues. I'll repeat the statement once again. I said, what is the problem in GBS? It is the immunological responses to non-host antigens like Mycoplasma pneumoniae, cytomegalovirus are non-human antigens, and the immune response is misdirected to the host nerve tissues. And then in this chart, what I've tried to show, this is from nature.com, it shows that once a person will get an infection, then there's going to be a production of antibodies, and you can notice that there is a incubation period. I mean, if this is day 0 when he's having an infection, the clinical manifestation will be having a range between 1 to 3 weeks. That's when the clinical manifestations will develop. Like, I'm just saying one here to say that first person might have paralysis of his legs, then subsequently the paralysis might occur in the trunk, then the paralysis might occur in the arms, then in the neck of this patient. So with 1, 2, 3, 4, I've just tried to say that there's a possibility that on the first day the legs got paralyzed. On the second day, there could be a possibility of truncal, then arm, and then diaphragmatic paralysis. Or instead of day, it could be first week of illness. In the first week of illness, only leg paralysis. In the second week, truncal paralysis. And by fourth week, there's a whole body involvement, including bulbar palsy occurring. Why it's important for you to know this is because when we talk about the progression of the disease per se, the symptoms of this disease can be so fast developing that within 12 hours, the whole body starting from feet upwards can be paralyzed, though in some cases, this would be going up to as much as 4 weeks as well. This period of degeneration before the plateau would come is important for diagnosis of GBS, because in the later part of the discussion, I'll be even using terms like CIDP. Remember, I said AIDP, acute inflammatory demyelinating polyneuropathy. I'll write on the full form also, but just listen to my data at the moment. The progression of GBS, that is AIDP, is usually in this range. It can be as fast as within 12 hours, or it can go up to as much as 4 weeks. And then we'll subsequently talk about progression occurring over 8 weeks also. That is CIDP, that is chronic inflammatory demyelinating neuropathy. So in MCQ of GBS, I would like you to also remember the duration of progression also. Lot of questions which will begin with paralysis in legs, progressing on to bulbar palsy, might be having answer as CIDP given. And I have students coming back to me and saying, sir, I mean, you taught us about AIDP and the question is saying CIDP. Why is that so? Because in chronic inflammatory demyelinating polyneuropathy, this manifestation might be over 2 months. In GBS, the deterioration of a patient, the deterioration of a patient can be as fast as over 12 hours or can be going over 28 days, that is 4 weeks. But if it's going to take 8 weeks for deterioration, that's an important point from MCQ perspective. If it's going to take 8 weeks, 9 weeks, 10 weeks for deterioration, then it's going to be answered as CIDP, chronic inflammatory demyelinating polyneuropathy. And then specifically with respect to Miller-Fisher syndrome, we'll be having eye involvement, extraocular muscle involvement can be present. So the nerves which innervate the muscles of the eyeball, they're enriched with GQ1B, and antibodies against it will then contribute to extraocular muscle paralysis occurring in this patient, which will explain the ophthalmoplegia that is seen in Miller-Fisher syndrome. Now, because I've been speaking extempore at this point of time, you might be wondering that, a lot of these terms might be sounding alien to you. So let's just do this quick practice for the various subtypes of GBS that I've been talking about. Like the commonest variety that we encounter is called as AIDP. Acute inflammatory demyelinating polyneuropathy. The highlight of this condition is that there is going to be anti-GMR antibody that will cause immunological response, a complement mediated damage, and you would be having motor features, sensory features, autonomic involvement as well. A lot of patients with GBS are admitted because they might be having postural hypertension, or they might be having wide fluctuations of BP, because thoracic nerves which are coming out of the spinal cord will also be denervated. As a result of it, even autonomic involvement can be present. So acute inflammatory demyelinating polyneuropathy as a disease per se can be having motor involvement, it could be having a sensory involvement, even autonomic involvement can be present. This is the commonest variety, but sometimes you might be having only motor involvement, and that too with electrodiagnostic study showing axonal degeneration. The term that I'm writing at the moment is called as AMAN, that is acute motor axonal neuropathy. This is also a variety that is seen in adults only, but on a comparison basis has a poor prognosis as compared to AIDP, because here it is predominantly the axons getting involved. Some patients could be having motor as well as sensory involvement as well. So the technical term would be acute motor sensory axonal neuropathy. Again, this is a variety which is one of the least common varieties with respect to adults, I can say. And with this, the prognosis would be relatively even much more worse. And then we have a variety that's called as Miller-Fisher syndrome. This Miller-Fisher syndrome that I have said earlier also is having anti-GQ1 antibody. And the highlight of this Miller-Fisher syndrome would be that cranial palsies can be seen, especially with respect to extraocular muscles, because the nerves that innervate these are rich in GQ1, and therefore antibodies would mainly contribute to development of ophthalmoplegia. In fact, there's a triad that I'm trying to cover here itself for Miller-Fisher syndrome, which would be occurring in less than 5% of cases of GBS. Overall, the most common variety that is encountered is anyway acute inflammatory demyelinating neuropathy. Miller-Fisher syndrome incidence is lesser, but look at the manifestations here: ophthalmoplegia, areflexia, and ataxia. OAA is the mnemonic which is to be remembered for the triad in this case. If he asks you what is the nerve that is getting involved in this ophthalmoplegia, then your answer would be third nerve palsy. Why it is important for you to remember this OAA is because there's a different mnemonic by the name of GOA that we study for Wernicke's encephalopathy. So I know that you are aware of this from other subjects as well, including psychiatry. But still, let's do a quick recap with respect to Wernicke's encephalopathy, which would be manifestation of dry beriberi and is due to vitamin B1 deficiency. The alphabet G in this case would be standing for global confusion. Then because the global confusion comes in primarily because one, this guy has been drinking for large number of days, plus there's a nutritional deficiency of B1 which would contribute to damage to the brain, and therefore the memory of this person is also getting hampered. Apart, like, this guy cannot tell you whether it is morning or evening. He cannot tell you the date or the time, or I mean whether he's in a hospital or whether he's in the home. Then alphabet O for Goa mnemonic would stand for ophthalmoplegia, and alphabet A is for ataxia. I decided to handle this here only because you can see the, ophthalmoplegia, areflexia, ataxia, couple of terminologies are coming out to be almost the same. Though you are picking up why I'm discussing this is because in Wernicke's encephalopathy, the cranial nerve that is involved is sixth nerve, whereas in Miller-Fisher syndrome, it is the third nerve that is getting involved. But because of this overlapping data, I thought that I should speak regarding OAA versus the mnemonic of Goa simultaneously itself. And then I have talked about various subtypes of Gullain-Barre syndrome. I'll fill up more details of these varieties subsequently, but at the moment I've tried to highlight regarding the full forms of these. I mean, these could have been in a printed format. No, I could have just underlined them. But why I did this activity is just to sensitize you to what's really happening. I mean, if we are having only motor manifestations occurring in a person, like in the form of a ascending symmetrical paralysis, then we'll talk about Amman, which has a relatively bad prognosis. If we are having motor and sensory, then we call it AMSAN. But if we are having motor also, sensory also, autonomic manifestations also occurring, and the electrodiagnostic studies are showing demyelinating pattern, then we call it AIDP, which at the moment should be remembered as the most common variety. I mean, the minimum that I expect you to remember for this particular slide is at least two data: the commonest variety, and then the full form of the triad that I mentioned for OAA for Miller-Fisher syndrome. Coming to the features of AIDP, this is going to be the commonest variety that is encountered in adults, and on the comparison between all the four varieties, this would be having rapid recovery. The neural target in this case is going to be the Schwann cell, and therefore the electrodiagnostic studies in this case, they are going to be showing evidence of demyelination. The demyelination part in MCQ can be written as increased distal latency, which basically means that because myelin is not there, the time required for the impulses to flow would be slowed. When we look at AMAN, that is acute motor axonal neuropathy, this is relatively more common in children or can be seen in young adults as well. The common antibody for both of these varieties, in fact, the top three varieties, is anti-GM1 antibody. And this time, if he says what is the neural target, then from a pathology perspective, you will answer this as nodes of Ranvier. I'm just trying to make it integrated with other subjects, like I was talking about culture media and antibiotics for Campylobacter jejuni. At the moment, I mentioned from a pathological perspective, what's the target of the antibody, where it's going to attack, and therefore there is going to be evidence of axonal degeneration on electrodiagnostic studies. As far as AMSAN is concerned, this would again be found in adults, but this is an uncommon variety on a comparison basis. And the target in this case would still be the nodes of Ranvier. Electrodiagnostic studies would still reveal axonal damage that can be picked up from English as well. For Miller-Fisher syndrome, there would be a triad. The details of triad have already been mentioned in the previous slide. That would be ophthalmoplegia, where third nerve palsy would be occurring, areflexia, ataxia. The antibody which is responsible for Miller-Fisher syndrome, however, is anti-GQ1B antibody, whereas the antibody responsible for problem in the top three varieties, the predominant antibody is anti-GM1. And in the FMG exam, they had asked which class of antibody here. So because the illness can span over days, therefore the class of antibody here would be IgG class of anti-GM1 antibody. In the later part of the discussion, I'll also talk about IgM class of anti-GM1 antibody. The disease that would be answered in this case would be very peculiar, multifocal motor neuropathy with a conduction block. At the moment, the data would look a little difficult for you to remember for the IgM class of antibody, multifocal motor neuropathy with conduction block. But yep, at least this term has to be remembered in totality, because the twist in the MCQ can be, and why I'm telling you this is right away instead of going later is because a lot of guys, they say, sir, you told anti-G1 antibody for GBS. The answer in the MCQ was different. That's because the class of antibody responsible for it is also changing. As far as Miller-Fisher syndrome is concerned and the neural target is concerned, then most of the time the findings which are found in Miller-Fisher syndrome, they are identical to that of acute inflammatory demyelinating polyneuropathy. But predominantly why extraocular muscles are involved in this condition is mainly because, as I said, the nerves which are innervating the extraocular muscles are rich in anti-GQ1, and the antibody targeting it results in development of this ophthalmoplegia manifestation. And as far as electrodiagnostic studies are concerned, the manifestation can be given as either of the two. Either it can be demyelination or it can be axonal, that could be described in electrodiagnostic studies. The main crux from this particular discussion is to get sensitized with respect to not only the features of Miller-Fisher, which I mentioned in the previous slide, but to mainly incorporate the neural targets for these antibodies, that is that Schwann cell versus nodes of Ranvier, and then again identical damage seen with respect to Miller-Fisher syndrome. We will next talk about clinical manifestations that develop in a patient of Gullain-Barre syndrome. So this particular chap woke up today morning. He had gone to a marriage party yesterday. He drove a car back to his residence as well. And today morning when he woke up, he was having weakness in the muscles around his ankle joint. And he thought that maybe he's fatigued due to excessive driving. But when he tried to stand up, he said that I felt as if I was standing on rubbery legs and I was able to stand with support, and the legs of mine were not able to take my weight. He somehow managed to go to the bathroom, but while he was coming back from the bathroom, because there's going to be hypotonia due to lower motor neuron manifestation of flaccidity, this person is going to fall. The paralysis will first develop in the muscles around the ankle joint, then will progress on to involve the muscles around the knee joint, and then will also involve the muscles around the hip joint. And because of paralysis of muscles around the hip joint, that is why this guy ultimately ended up in a fall. So initially everybody thought, even a non-medico will think that maybe I slept in some wrong position and my leg muscles, the nerves which are innervating those leg muscles got compressed, and therefore I'll take some rest and I'll be okay. But unfortunately, in this person, there is a possibility that today this paralysis which is occurring in the legs, and the paralysis in the left leg will be equal to paralysis in the right leg. The same patient where family members are thinking, okay, he might get better by evening or maybe tomorrow morning, he may even develop inability to sit up in the bed due to truncal paralysis. So most of the time, the description, the clinical features which are going to be given to describe this ascending symmetrical flaccid paralysis are going to be so in your face that it is very hard to miss. The bad news is that this guy can then develop even arm paralysis on maybe third and fourth day, and then even neck muscle involvement will occur. That is neck floppiness. While I'm writing 5 and 6, I'm saying this guy is now quadriplegic. Imagine a guy who drove a car back from a wedding ceremony, maybe of his cousin a few days back, is now battling for his life in the hospital on a ventilator. Why? Because if there's a neck involvement, if there's going to be shoulder involvement, if there's going to be arm involvement, that means cervical spine demyelination is also occurring. And cervical demyelination implies that if you have demyelination C3, C4, and C5, then diaphragmatic paralysis will ensue, and that will cause a ventilator requirement of this person. In a large number of these patients, even cranial nerves can be involved. The commonest cranial nerve involved in Gullain-Barre syndrome is the seventh nerve. There would be a manifestation of facial diplegia. Facial diplegia normally we read either with Guillain-Barré syndrome or with sarcoidosis. Let me just jot these features down. I mean, this individual, he says, I woke up in the morning with weakness in the legs. Like a lot of time, person might use the word rubbery legs to describe the weakness. And then he says that somehow with support, I was able to go to the washroom to urinate and defecate. But then when he was coming back from the washroom, he fell down and then he says, I could never. He says, sir, I got the shock of my life. I mean, I'm not able to stand. So that's going to be the initial presentation of these patients. The progression of weakness in this condition can be ranging from as fast as in 12 hours. This guy might be like he started his leg weakness at 8 a.m. in the morning, and by 8 p.m. today he could be having this paralysis in his arms and cervical spine getting involved, and he is having a ventilatory requirement. The diaphragmatic paralysis part would come in some cases. However, you will notice that in the first week there might be weakness in only both legs, and then it will go up from bottom to involve both the arms also. So like week 1 it was legs, and week 2 it was trunk, and week 3 it's gonna be the arms of the patient. So it can be spanning over a couple of weeks as well. The upper limit where the maximum amount of weakness is obtained is approximately 4 weeks. This is the important diagnostic criteria. The progression of weakness can be as fast as between 12 hours to 28 days, and this is to be included in the diagnostic criteria for this case. As I explained, truncal paralysis and then subsequently quadriplegia implies bad prognosis, especially arm paralysis, especially biceps, because if biceps is involved, it implies there is a involvement of C5, and that involvement of C5, because C5 is a common root value between the diaphragm and the biceps. So that implies, I mean, if he is lying in the bed and he can't even flex his arm, he's simply lying in the bed, he can't even involve flex his arm, it implies that remyelination is occurring in the cervical part of the spine as well, which is why I said quadriplegia and neck floppiness would be occurring. So it's a unfortunate quick neurological degeneration that would be occurring in this case. And then the most common cranial nerve involved in this person would be the seventh cranial nerve. Bilateral seminal palsy is present. Do not confuse this bilateral seminal palsy with Bell's palsy, because Bell's palsy is going to be unilateral. I mean, the technical term that I verbally said and I'm writing it once again is facial diplegia. Traditionally, diseases where you read facial diplegia, one is going to be sarcoidosis, because you have non-gazetting granulomas that are present in sarcoidosis in the parotid gland, and they can press on the seventh nerve, which is why facial diplegia can be seen. Another one to be remembered is the topic of interest at the moment, that is GBS. There's a rare one also, Melkerson-Rosenthal syndrome, but no point of getting into a rare syndrome. We just need to remember the common data in this particular case. And then the prognosis is even gonna be worse off, because the base of the brain will also get involved. If the base of the brain will be involved, the cranial nerves coming out of the base of the brain, like the 9th, 10th, and the 12th nerves would be affected, and therefore this guy will not be able to even eat or chew, or even handling airway will become problematic, because gag reflex will be lost, cough reflex would be lost, and therefore there would be a substantial amount of difficulty in handling secretions. I mean, things that we don't even think about, no, like swallowing our secretions, swallowing our saliva, or like eating, drinking, talking. We keep on doing eating, drinking, talking the whole day. We don't think about, that which muscles are coordinating this activity. But once the cranial palsies will occur, bulbar palsy will result in absent airway reflexes. And if a family member, out of pity for this person, tries to put some, 2 drops of water. See, they say like this, I just put 2 drops of water in the mouth. They made him gulp water, and the water will go in the lungs of this guy. Though they'll say, I put only 2 drops. I was trying to wet the lips of this guy because they were dry and he had not eaten anything. But then aspiration pneumonia is one of the important reasons why these patients can ultimately die. So if the question simply says, what is the leading cause of death in patients of GBS, your answer would be given as secondary pulmonary involvement. By secondary pulmonary involvement, he tries to incorporate everything ranging from diaphragmatic paralysis. I mean, obviously there is going to be diaphragmatic paralysis, so there's going to be buildup of carbon dioxide. So he can also go into respiratory system. He can say respiratory acidosis. You're aware, whenever there's a buildup of carbon dioxide in the body, it will cause generation of protons. So it will cause respiratory acidosis, or he might write it as type 2 respiratory failure. in about 30% cases of Gullain-Barre syndrome, diaphragmatic paralysis will occur, ventilatory support would be required, and lots of time this may not be available if he's going to a smaller hospital or district level hospital, and as a result of it, a lot of these patients can die. Luckily, when your patient will recover, point number 8 is a sensory manifestation. Most of the time, the sensory manifestation that I'm now describing for this particular patient would be elicited only when the person is on the path to recovery. Point number 8 implies that even the spinal cord is getting affected, so therefore proprioception, you see proprioception is carried by the dorsal column. Traditionally, we read about proprioception loss with subacute combined demyelination of the spinal cord with vitamin B12 deficiency. But today I'm saying that even in GBS, we do have a proprioception loss present. How this proprioception loss will manifest? Well, this conscious proprioception is lost, so person will be having difficulty in climbing of stairs, and this presentation of difficulty in climbing of stairs could have occurred a few days before he actually could not walk. A lot of patients initially will not be able to pick this up. You see, proprioception means joint and position sense. Like if you go to a new place, no, if you're climbing a new pair of stairs in your house, the stairs you've been going up and down so many times that your brain has approximated the height of stairs, so never a problem. But every time you go to a new place and there is gonna be stairs, and let me say they are of uneven height, then you have to be careful, otherwise you and me can trip and injure ourselves as well. So proprioception loss might be appreciated in this individual, especially when he's climbing stairs of a new place, maybe in his house, because we are subconsciously having in our brain muscle memory with respect to how many stairs are there, what is the height of stairs, no problem. But if he had been to a new place prior to the onset of this motor paralysis, then complaints of proprioception loss in the form of difficulty in climbing stairs and maybe falling in the stairs could have been present. And the sensory manifestation in these patients could be pain in the neck. That is before the onset of this paralysis. Majority of these patients would tell you regarding point number 8 only when they are on the way to recovery that initially he also was having pain in the neck, pain in the arm, pain in the shoulders, and the pain would be like one that is described over exercise muscle. Most of us doctors know we keep on sitting at one place and keep on studying the whole day, and then suddenly after 7 or 10 days we realize we are putting on weight and we decide to go to a gym. Now suddenly you go to a gym after 10 days and you will do over exercise of one muscle, it's going to become very painful and tender on the next day. So similar kind of pain that we get in a over exercise muscle, a similar kind of pain that you get in a over exercise muscle, or if you're exercising after a very long time, the pain that comes in the muscle, that kind of pain could be described in these patients in a retrospective. This that I'm describing, there is a possibility he might have come to the doctor initially for these complaints as well. And it is not the fact that these manifestations cannot occur after motor manifestations, but a lot of time the motor manifestations might cause person not being able to talk. And if a person will not be able to talk, then point number 8, though it is present, it may not be elicited. I mean, a person who cannot talk cannot explain to you regarding the pain in his arms. If he can talk, it's okay. Like, let me say, if there is no bulbar palsy in our patient, if there is present gag reflex, present cuff reflex, he is in a position to talk at the moment, and the paralysis is still not involved, even the cervical spine, only up to the thoracic spine involvement is present, then if he can talk, then he can explain these manifestations to you now as well. So sensory manifestations can be occurring before motor manifestations, that is one, or they can be occurring along with motor manifestations as well. I repeat that fact once again. Sensory manifestations can be present before the onset of motor manifestations, or can be occurring with the motor manifestations as well. Though most cases who come to us in the case that would be given to you exam will be mainly of motor involvement. Then one of the highlight of this condition is the involvement, rather I would say the sparing of the bladder and the bowel. I mean, bladder and bowel most of the time is gonna be spared, or I can write it in a different fashion that sometimes they can be transient involvement of the bladder as well. Let me just write it once again. I said majority of cases there is gonna be sparing. The textbook says, and that is, what is to be remembered, if there's a predominant bladder bowel involvement, and there is also sensory level, like below a particular level, like patient is trying to tell you that below my umbilicus I feel as if somebody is pouring acid over my legs, or I feel as if somebody is pouring boiling water over my legs. If you are having a sensory level predominant bladder bowel involvement, then you think in terms of a differential diagnosis of this condition, that is by the name of transverse myelitis. So I'll write this very categorically, either you're gonna be having sparing or you might be having a transient involvement but not a continuous involvement. If you're having a predominant bladder bubble involvement with a sensory level documented, here the sensory complaints are like pain in over exercise muscle, or some patients might be describing even dysesthesia, that is burning sensation in the extremities as well. So that's another sensory manifestation, I can say. But overall, I mean, if you look at the data that I've provided to you, majority of question, the space in the MCQ, I mean, if it's like a 3-liner or 4-liner MCQ, majority of space is going to be taken by the motor manifestations, and the sensory manifestations either will be not described or would be very limited. Like suppose if it is Aman, no acute motor axonal neuropathy, then there would be no sensory involvements occurring in this patient. So it's predominantly motor manifestations. Then over and above this, even autonomic involvement can occur, like we can be having demyelination with respect to the thoracic spine as well. Due to the autonomic involvement, there could be wide fluctuations because the regulation of control over the heart would be lost. So there would be wide fluctuations of blood pressure. In fact, that is one of the indications for admitting these patients apart from development of type 2 respiratory failure. Diaphragmatic paralysis is the indication. Wide fluctuations of blood pressure is again a reason for admitting these patients, and the wide fluctuation of blood pressure could then put stress on the heart, and it could even cause, I mean, ischemia or myocardial ischemia, because if BP will suddenly rise, it will cause myocardial ischemia. Heart will have to work harder, and that can trigger even arrhythmias as well. And therefore, it is no big deal that in questions of GBS, he might even describe uh, postural hypotension. This postural hypotension is because I can say neurogenic shock. Neurogenic shock implies that there would be a bradycardia with a hypotension. In fact, that's itself a question, which variety of shock presents with bradycardia, because you're aware that all varieties of shock always cause a tachycardia. But shock which is causing demyelination of the spinal cord, see, in the heart you have vagus innervation, sympathomimetic innervation. If sympathomimetic innervation will be damaged, then vagus activity will predominate, and vagus activity, when it will predominate, it can result in development of bradycardia. Due to bradycardia, the cardiac output will decrease, and that can cause hypotension in these patients as well. So, in fact, I mean, this is itself a question that which variety of shock would be having presence of bradycardia. It is neurogenic shock, and one of the causes for development of neurogenic shock is what we are discussing at the moment. That would be Gullain-Barre syndrome. The learning point at this juncture is that for point number 1 to 7 that I've described for this topic, that's predominantly motor manifestations. Point number 8 that I've focused here is sensory manifestations. Then I've talked about bladder and bubble, usually spared, or even if it is present, it would be a transient involvement for a few days and then everything. I mean, he would be able to control his bladder, and then autonomic involvement can occur. Everything that I've written on this slide, if all these manifestations are occurring in a patient, you will write GBS query AIDP, acute inflammatory demyelinating polyneuropathy. While you put on a query is because you need electrodiagnostic studies to prove the demyelination part. But if these are the manifestations that are described, we will say a person is having AIDP. Now, suppose in a patient, clinically speaking, the manifestations are only motor. I mean, point number 1 to 7 is there. There is no sensory description given. There is no, I mean, bladder and bubble is anyway spared, and there is no autonomic involvement also present. Then we'll clinically put it as query Aman. So GBS as a diagnosis is based on presence of clinical features along with evidence of electrodiagnostic studies, and therefore I'll be subsequently mentioning before you what are called as Brighton criteria for diagnosis of this condition. But before I write those Brighton criteria, we also need to focus on the workup of this patient, and the workup of this patient will always say a very characteristic term that I'm saying right now, that is cytoalbuminological dissociation. What that implies is that because it's an autoimmune condition, the proteins in the CSF will be elevated, but the cells will mostly be normal. So normally it doesn't happen like this. Whenever proteins are increasing, cells are also elevated. But in this condition, the cell count in majority of cases would be normal or might be showing a slight elevation, never a permanent. It might be a transient elevation for a few days. But subsequently, the main crux is when you have a substantial increment of protein, and majority of reports that will be given to you in your exam would be in black and white only. In a sense, what I mean by black and white is that they'll mention normal cells with grossly elevated protein, and that I've described even in CNS infections also, that every time we read about a CSF report where everything else is normal and the protein being grossly elevated, by gross elevation, again, I don't mean up to the level in tubercular meningitis, no cobweb coagulum, but yeah, elevated up to 1 gram. Though the cell count is normal, that is cytoalbuminological dissociation, which would be an excellent pickup point in case you are not able to remember these details. Coming to the workup of this condition, the first test to be done is the lumbar puncture. And when I'm going to check out the report, you will notice that everything is going to be normal. Count is normal of the cells, opening pressure is normal, sugar values are normal. And you'll be wondering to yourself, why has he given you a normal report? But the moment you arrive at protein, you will know the reason, that because this is an autoimmune condition. Autoimmunity means antibodies attack against self. The protein values in the CSF would be mentioned in a range of about 100 to 1000 milligram per deciliter. Normal value of CSF protein is 15 to 45 in double digits. Here it will be going up to 3 digits and even 4 digits as well. But there would be normal cell count, which he can write as without pleocytosis. See, if the examiner is kind on us and he prefers to use this terminology, that is cytoalbuminologic dissociation, then it is cool. I mean, if he's kind on me, I'll be able to diagnose GBS right away. I mean, whether I will answer AIDP or not will be based on electrodiagnostic studies. But if he gives this term, it means that he's talking about the broad spectrum GBS, and GBS then has a spectrum of the four varieties, that was AIDP, Aman, Amson, and MFS, that was Miller-Fisher syndrome. In each variety of these, albuminocytological dissociation has to be demonstrated. I would also like you to remind you that the CSF study, I mean, there is no rush into doing a lumbar puncture. The CSF study report can be perfectly normal. That means even the proteins can be normal in the first 48 hours of presentation. So early onset presentation, like he is presented with paralysis only around his ankle joint, and or maybe around his knee joint, and is having difficulty in movements. When he came to the hospital, I did a lumbar puncture. The CSF study can be normal, but as the disease will progress after 48 hours, proteins will begin to rise, and the maximum rise of protein is seen by day 7. The maximum rise of protein, I mean, the values going up to 1000 might be seen by the 7th day. So it is a possibility that if a patient has come to the hospital early and we have done lumbar puncture, the report of the CSF can be normal. But then when we repeat the CSF study in the same case after a few days, then these classical derangements that I've described would be present. Electrodiagnostic studies would also help us knowing regarding the subtype that is present. Like the commonest variety is AIDP. To make it sound like, if he just says no slowed nerve conduction velocity, it would be very easy. So to make it sound sophisticated, the MCQ will say words like prolonged F wave latencies. What that basically means is, what do you mean by the word F wave latency is that the time required for the current to go to the spinal cord and come back from the spinal cord, the total time will be increased, because see, the nerve roots which are coming out of the spinal cord are demyelinated. So the time taken for the impulse to take a complete, we study a reflex arc in physiology. So there's a diagram showing current going to the spinal cord, coming out of the spinal cord. So I'm talking about the reflex arc only, that the time taken for the current to navigate across the reflex arc will be slowed, because there's a demyelination, there's damage at the nodes of Ranvier, which is why prolonged F-wave latencies can be given in a question. This is the earliest electrodiagnostic finding with respect to acute inflammatory demyelinating polyneuropathy. If you contrast this with Aman or Amsan, there the electrodiagnostic finding will be reduced compound muscle action potential, but the nerve conduction velocity in that case would be maintained. So CMAP is mainly related to axonal damage. Compound muscle action potential is mainly related to axonal damage, whereas the F wave latency or reduced or slowed nerve conduction velocity or conduction block are terms which would be favoring presence of AIDP in the case. So on the basis of this information, we will now be in a position to understand regarding Brighton criteria for diagnosis of GBS. Now, coming to the Brighton criteria, we can remember them easily by a mnemonic by the name of FAME, where alphabet F would stand for that there would be a flaccid paralysis. The paralysis that occurs is bilaterally symmetrical as well. It would start from the ankle joint, move up to the knee joint of this individual, and therefore the second feature that needs to be demonstrated is areflexia. In fact, if he says that which is the first reflex to be lost in patients of GBS, then answer is ankle, then subsequently the knee jerk also gets affected. So we need to demonstrate that there is a areflexia in the weak limbs of this patient. This would be associated with flaccid weakness. Then the next A to be remembered is A from the cytological albumino dissociation, which implied that everything is going to be normal, but the protein values are going to be grossly elevated, that is up to 1 gram of protein elevation can be seen. But I hope you remember that this may not be present in the first 48 hours, and the rise of protein will take up to 7 days. The next feature is one of the most important one from the MCQ perspective, that is the illness is a monophasic illness. What I mean by monophasic illness is that from the onset to the nadir of illness, that is the max amount of weakness would be seen by about 28 days, though it can be progressing as fast as over 12 hours. And then subsequently there would be a plateau. I showed a curve to you initially. In that plateau phase basically means that the weakness will remain static, and then gradually the weakness of this person will begin to evolve. Alphabet E would be mainly for electrodiagnostic studies or electrodiagnostic findings, which would be consistent with that of GBS. Like I mentioned, technical terms like prolonged latency of the F reflex, or you might write delayed distal latency, or decreased compound muscle action potential because there is damage to the nerves present. So alphabet F is for flaccid paralysis. The alphabet A is being used 2 times here. That is for areflexia and albumino part of cytoalbuminological dissociation. M stands for monophasic illness, important because if he's giving you everything like this, but the illness is going over 8 weeks, 10 weeks, 12 weeks, then don't answer GBS, then answer it as CIDP, chronic inflammatory demyelinating polyneuropathy. If this is going beyond the phase that I mentioned, I mean 12 to 24 hours is the usual range for the progression of the max amount of weakness present. And the electrodiagnostic findings is the alphabet E present here. So that's a mnemonic that helps us remember the manifestations. Even in Miller-Fisher syndrome, the logic would still be the same. It's still gonna be, I mean, the features are slightly different. I mean, instead of flaccid weakness of limbs, there would be ophthalmoplegia. There would be a bilaterally symmetrical ophthalmoplegia, in fact, with ataxia and areflexia. But then at the same time, the remaining features are still the same. Miller-Fisher syndrome, if he says what happens to CSF finding, your answer is still the same: albuminocytological or cytoalbuminological dissociation. If he talks about what's going to happen to the reflexes in these patients, it's going to be absent. That was anyway present in Miller-Fisher syndrome. In fact, I would like to tell you characteristically that Miller-Fisher syndrome as a disease would be having areflexia, but it may not be having muscle weakness. So do not be surprised if during the literature or MCQs of Miller-Fisher syndrome, you might notice this term written areflexia without weakness, because mostly the impression is that if areflexia is there, there's going to be weakness also present. But in the early phase of Miller-Fisher syndrome, areflexia can be described without weakness as well. That's in the same spirit like I was saying, lumbar puncture findings can be normal in the initial 48 hours, and then they'll be showing a deterioration. Coming to the treatment part, we'll be giving intravenous immunoglobulins, which is the drug of choice slash treatment of choice for management of this condition. There's an alternative approach also available where we can go for plasma exchanges. That's plasmapheresis. But then as far as plasmapheresis is concerned, this would be requiring a much more extensive setup and will also be relatively more expensive as compared to intravenous immunoglobulins. Overall, this is anyway expensive disease to treat, because if person is requiring ventilatory support, he has to be in the ICU. So per day hospital charges will be substantial along with the cost of IVIG. But plasma exchanges would require even much more extensive setup, and lots of time facility for the same may not be available. You see the effectiveness of both of them, both intravenous immunoglobulins and plasmapheresis, when they have been tested in clinical studies, they have been found to be equally effective. So the query in mind of most doctors is that what should we answer in the exam for the treatment of choice for this condition. For drug of choice, it's okay, IVIG answer, but for treatment of choice also I'm saying IVIG because it is relatively easy to administer. Then the query in mind of a lot of doctors is that why don't we combine the two approaches? Well, the combination of two approaches has not shown an increase in the functional recovery of this patient. So as such, he says that use either of them, whichever is available. If intravenous immunoglobulins are not showing a response, we can use plasmapheresis as well. But as far as recovery is concerned, I mean, the functional improvement in the person does not occur immediately. Like suppose you have given 5 injections, we give once daily injections of immunoglobulin, 5 injections of IVIG have been given over the past 5 days. So the relative is saying that no, his leg is not moving or his arm is not moving. So most of the time the functional improvement will occur, but this functional improvement occurs usually after about 7 days of giving the treatment. Like suppose immunoglobulins were given today, then the improvement might be seen after 7 days, or in some cases it could be even a delayed response as well. So we need to keep patience with respect to the functional recovery that would be seen. It's not that we give IVIG right now and there would be like the person will start moving his legs or he'll start moving his arms. That's not going to happen. It usually occurs after 1 week of initiation of treatment. So it's a gradual process, and the patient and relatives both have to keep patience. Then comes an important aspect. Can we use steroids in this condition? No, glucocorticoids are not useful for this condition. You see, the damage has already occurred. Steroids will prevent formation of new antibodies, but the damage has already been occurred by the antibodies already in the circulation. So I need to act fast and remove those antibodies. See, here it's not about that glucocorticoids will prevent further antibody production. Whatever currently the antibody, the harmful antibody that's present, I need to remove it from the circulation either by giving antibody against antibody, or if I'm not giving an antibody against antibody, then I will go for plasmapheresis in this patient. So any of the two approaches can be used, but on a comparative basis, IVIG should be answered as the primary treatment of choice for this condition. And overall, the condition has a satisfactory prognosis with respect to 85% of these patients will make a full recovery. By full recovery, I don't mean that he's a marathon runner, so after 1 year he will start doing marathon running. That's obviously a long drawn process. But yeah, ability to take care of his body, ability to ambulate would very much be present in these patients. The reason for development or death in Gullain-Barre syndrome is secondary pulmonary complications. These secondary pulmonary complications can range from diaphragmatic paralysis to carbon dioxide retention causing respiratory acidosis, barotrauma, ventilator-associated pneumonia, atelectasis of lungs, segmental collapse of lungs. So multiple lung-related complications can develop, and because some of these patients might be requiring long-term ventilation, we may not even intubate and might even do a tracheostomy for these patients. What I say next is an important part from the exam perspective, that is CIDP, chronic inflammatory demyelinating polyneuropathy. In chronic inflammatory demyelinating polyneuropathy, the clinical manifestations will be given to be I would say in a same way as that for standard GBS, that's leg paralysis, then arm paralysis, truncal paralysis, and the deterioration part is the only thing that would be the differentiating factor. If the deterioration is occurring over a duration of weeks, that is more than, you see, in GBS, the term that I was using was maximum upper limit of weakness, maximum, severity of weakness was by 4 weeks. Here, the progression might be going even beyond more than 9 weeks of onset. So that term, the duration part is important for diagnosing it as AIDP versus CIDP. And why that's important is, guys, because CIDP we use steroids. Look at the paradoxical shift that I'm seeing at the moment. Like I was just few minutes ago, no, I was saying steroids have no role for management of GBS, but now I'm saying steroids are one of the approaches that we use for management of CIDP. So one, remember this feature that it manifests. It will look like GBS, but the progression part would be slightly different. So that's a point to be remembered. And here I get a query because a couple of apps would be mentioning 8 weeks in this particular case. So I am mentioning Harrison for this one, though even Adams neurology would be saying slightly different data. So this is page number 3-5. You can check out by yourself itself in Harrison 21st edition. S21 means Harrison 21st edition. This is slight of controversy because some apps would be mentioning 8 weeks here. Harrison mentioned 9 weeks. Or another definition of this condition is also there. That is a relapse. The manifestations of GBS can relapse at least 3 times. The relapse part, I think, is not very important. So I've not written that in bold in a sense on a comparison, that if GBS manifestations are occurring again and again, then I'll not say AIDP, then I'll say chronic inflammatory because the relapse part is there. So most of the time it's with respect to the deterioration part or the progression part of the weakness that you need to remember, chronic inflammatory demyelinating polyneuropathy part. And then the second aspect for CIDP is that the treatment of chronic inflammatory demyelinating polyneuropathy, we can be using intravenous immunoglobulins, but along with this, we will also use steroids. So that is the main reason why he wants to incorporate this information, that steroids would be used mainly in CIDP and steroids would not be effective for management of AIDP. Lastly, to finish this topic, I mentioned regarding two extremely rare subsets with respect to GBS. One is acute pharyngeal cervicobrachial neuropathy, in which the presentation would be just like GBS, but will begin with paralysis in the arms and would be involving the throat as well. There would be involvement of the neck muscles as well. In this case, the antibody that is responsible is anti-GT1A antibody. So just our vocabulary has increased. I spoke about anti-GM1 antibody for Aman, Amsan, and then for AIDP. And then I spoke about anti-GQ1B antibody for Miller-Fisher syndrome. The last one to be remembered, I did bring to your notice one earlier also, that is multifocal motor neuropathy with the conduction block. As the name suggests, patient will develop multiple individual neuropathies, starting with maybe a wrist drop, progressing onto a development of a foot drop. In this case, the antibody that's present is still anti-GM1, but this would be IgM1 class of antibody. And along with this, there would be electrodiagnostic evidence of conduction block as well. So these are two additional details which are to be remembered, especially from the perspective that if he mentions IgG class of anti-GM1 antibody, then answer it as AIDP. If he mentions IgM class of antibody to anti-GM1, then your answer is multifocal motor neuropathy with a conduction block. So these are the details that I would like you to remember for this topic. Keep the pressure on, keep on learning new facts. We did talk about a couple of these antibody names that might sound a little irritating to remember, but then they're worth the hard work that you guys are doing. So keep learning new facts every day, guys. Thank you so much.